Thanks, Andrew. And my pleasure to be speaking again today on IV fluids. I'd say compared to a couple of the other talks, this is an area that I'm especially passionate about and excited to be discussing this afternoon. In terms of disclosures, same as what I've mentioned before, I am a guideline consultant for a couple of societies. What I didn't put up here is that I'm also a PI for a fluids study, which I'll talk about a little bit more during the presentation, called the FISSH trial. We'll talk a little bit about commonly administered IV fluids, both in sepsis as well as critical illness in general, and obviously integrate the best evidence that informs that fluid resuscitation. This diagram is perhaps familiar to most and mimics sort of that classical training about distribution of different fluids amongst the physiologic compartments. And as you probably know, things like hypotonic fluids like 5% dextrose are very poor resuscitative fluids, because a lot of the fluid ends up in the intracellular space as well as the interstitium. Isotonic fluids, like balanced crystalloid or like normal saline, a lot more of that fluid stays in the intravascular space and less leaks out into the interstitium. Colloids have the theoretical advantage of all staying in the intravascular space. They have a large compound molecule, can't cross the semipermeable membrane, and even has the added advantage of perhaps drawing fluid in through osmosis. This classical teaching of crystalloids and colloids that we all get taught, I would argue, is relatively simplistic. And I think it's instead crucial, especially when we think about colloids, to think about the individual components of each of these different fluids. We'll go into the individual components of both crystalloids and colloids. As I mentioned, let's start with colloids. These are probably, barring blood products, the ones that are most commonly administered and the ones that are most commonly used. Starches used to be very widespread administered, ubiquitous in the critical care and perioperative setting. And I think you're all familiar with the increasing amount of data, specifically in the early 2010, 2012 range, suggesting harm using starches. These were probably one of the most famous colloids, and a lot of the perhaps mechanism and harm associated with starches was through acute kidney injury and bioaccumulation within the kidneys, which also increased signal for mortality. Gelatin and dextran both have very poor data in terms of efficacy, and I'm not sure about here in Singapore, but at least where I practice back home in Canada, neither are available given the costs and the lack of benefit. And when we talk about colloids, this really leaves us with albumin as the main potential colloid that we might administer to critically ill patients. Really speaking about 5% albumin. The hyper-oncotic 25% albumins are less commonly used as resuscitative fluids. Talk about albumin for a moment. This is the most recent meta-analysis looking at albumin as a resuscitative fluid when compared to crystalloids. The individual trials aren't as important, but I will highlight the bottom line pooled point estimate right around 1. This suggests that no matter whether your approach is to use albumin as your primary fluid or crystalloids, the impact on mortality, which is the outcome reported here, is equivalent. And obviously that there's other issues with using albumin, both costs, much more expensive than crystalloids, but also the potential exposures of it being a blood product as well. And given the fact that albumin appears to be equivalent, at least, to administering crystalloids, I would argue that using albumin as your upfront first choice resuscitative fluid is probably the wrong thing to do. Now, maybe some of you are thinking about you do use albumin in your daily practice, and I'll admit I do as well, but I don't use it as my first choice resuscitative fluid. The way if I do use albumin is that I start perhaps with a little bit of crystalloid. Maybe once I see that albumin stock drops down as it is an acute phase reactant, is that I'll think that administering albumin, perhaps restoring that oncotic pressure, might cause some benefits. And despite that's the way I practice, and maybe that's the way some of you practice, is that there's not a lot of good trial data examining the role of albumin in a setting like that. So I can't tell you whether using albumin after a few liters of crystalloid is the right thing to do or the wrong thing to do. I also can't tell you that continuing to just administer crystalloid is the wrong thing to do. But what I can tell you, as I said, is that I think that using upfront albumin is probably the wrong thing to do given the fact that there's no benefit and only cost. Let's move on to crystalloids. In terms of crystalloids, there's probably two big categorizations. And there's normal saline, which I think a lot of us are familiar with the fact that despite the fact that it's called normal saline is far from normal, containing a sodium content 10% higher than that of ECF and a chloride concentration 50% higher. And at least in animal models, we have a building body of evidence to suggest a number of harmful sequelae, including the effect on renal blood flow and GFR, the effect on smooth muscle activity, in addition to hyperchloremic acidosis. This as compared to balanced crystalloids. When I talk about balanced crystalloids, I'm talking about things like Ringer's lactate, Ringer's acetate, newer formulations like plasmolite. And they're able to get away with a lower chloride concentration by replacing the chloride with an organic anion. Again, things like lactate or acetate. Despite the number of different options available, at least at my own center, we primarily administer Ringer's as our balanced crystalloid of choice, and there's surprisingly little data comparing these balanced crystalloids to each other, at least for patient-important outcomes. This is work that I did as part of my thesis for my degree in health research methodology, and we looked back on all the randomized controlled trials that have looked at administering different intravenous fluids in the setting of sepsis. And unsurprisingly, we know that there's varying concentrations of chloride amongst the crystalloids. Surprising to us in doing this work is that there's different formulations of albumin and different chloride concentrations in different albumins. This is something that we weren't aware of. And it led us to a bit of an offshoot project or a side project, is that we looked at the 5% albumins that were available at the hospital at our own center. There was 3 different ones. And we wondered, what is the chloride concentration of these albumin products? It's the same albumin products that in fact are available across all Canadian hospitals. Before embarking on this, we tried to find out different ways by contacting industry reps to see if they could tell us what the chloride concentration of their albumin products were, and a lot of the industry representatives were unsure. So what we ended up doing, we got a small grant, is that we ran the albumin samples on the serum chloride machine to see what the chloride concentrations were. And here you can see the 3 different products. Again, I don't know what the products that are available here in Singapore, but we had 3 different manufacturers. And when you look at the chloride concentration, it varied quite drastically. There was some 5% albumin products that looked very similar to Ringer's lactate or balanced crystalloids, and other albumin products that had a much higher chloride concentration, more similar to that of saline. Again, very interesting that the blood bank decides which one of these to administer just depending on which is the next one available on the shelf, and nothing to do with patient factors. Back to crystalloids, because I think that this is a lot of the ongoing debate in the last little while. Does it matter which crystalloid I give? I've shown you the fact that we do see differences in animal studies, but does this translate into patient-important outcomes? And there's probably 2 schools of thought when it comes to this. There's the one school of thought that says, you know what, normal saline works just fine. And despite the increasing work that's been done in the last little while, is I'd say normal saline remains the most widely used fluid internationally, and probably also the cheapest, although the cost difference is quite minimal between other cheaper balanced crystalloids and saline. There are some animal data that suggests that hyperchloremia may in fact be protective, and I think we'll hear a little bit more about this in one of the upcoming talks in this session, and might be protective against hypoxic stress or stimulating for white blood cells in the setting of infection. And up until very recently, the largest randomized controlled trial we had that compared balanced crystalloid versus saline was the SPLIT trial, done right here in the backyard in Australia, New Zealand. Cluster crossover in 4 centers, and it showed no difference between balanced crystalloid and saline in terms of the outcomes of mortality or need for renal replacement therapy. Important caveats being that there was low volume of fluid exposure in relatively healthy patients, and that's a common theme amongst fluid trials, as you'll see. The other school of thought, and probably the increasing school of thought, is the folks that say, I can't believe you're still using normal saline. And the evidence that these people will point to starts with probably the earliest data, again done in Australia, was a before and after trial done by Yunus and colleagues, where they had a period of time where they only administered low chloride fluid, a washout, and then a period of time where they only administered high chloride fluid. It wasn't an RCT, it's a before and after design. And what they found was that in the low chloride fluid period, there was lower rates of acute kidney injury and acute failure by rifle criteria. We performed our own network meta-analysis looking at different intravenous fluids in the setting of sepsis. For those that are unfamiliar with network meta-analysis, this is what's called a network map. And what it does is it summarizes all the different fluid trials. Again, this is in the setting of sepsis that have compared different fluid types. Saline's at the top, balanced crystalloid is the BC at the bottom. Light starch, heavy starch are the two orange circles, albumin in the middle, and gelatin. Each of the black lines represent randomized controlled trials, head-to-head trials that compared two of the different fluids. In the setting of sepsis at least, or strictly in sepsis, and at the time we did this network meta-analysis, you can see that there's no black line that's connecting saline with balanced crystalloid. This is because nobody had done a head-to-head trial at the time. But what network meta-analysis says is that despite the fact that saline and balanced crystalloid have never been compared head-to-head, if saline has been compared to light starch, and light starch has been compared to balanced crystalloid, again in randomized control trials, why can't we make comparisons from saline to balanced crystalloid through that common comparator? And again, that's the idea behind the network meta-analysis. And when we did this, incorporating indirect evidence, we found a signal for benefit for balanced crystalloid in terms of mortality and need for renal replacement therapy. These were low certainty of evidence when we applied grade. There's issues specifically with imprecision. You can see the upper end of the confidence interval crosses 1, but still perhaps a signal towards benefit. Probably most pressing and what's really stimulated some of the discussion around fluids in the last little while is publication of 2 trials that were led by the group in Nashville, and one in a critically ill population and one in a non-critically ill population comparing saline versus balanced crystalloid. And we'll talk about both of those right now in turn. The SMART trial was the one that looked at the critically ill population. This was a cluster randomized, unblinded, multiple crossover RCT done in 5 ICUs at Vanderbilt and compared balanced crystalloid, either plasmolite or Ringer's lactate, with saline. Their primary outcome was something called MAKE30. This is a composite outcome. It includes need for renal replacement therapy, death, and persisting acute kidney injury at 30 days. This is what the randomization schema looked like. Again, 5 ICUs, and what they were randomized to was the starting fluid. So they were randomized to what fluid they started with, and then the ICUs crossed over month by month by month for a period of 2.5 years, or 2 years. Interestingly, and again, I suggested this earlier when I was talking about the split trial, is that when you look at the details, patients that were randomized to one arm or the other received about 1 liter of study fluid. Now, they did try to match up the fluid that patients got either in the emergency department or in the operating room based on what fluid the ICU was receiving that month. So in totality, it was probably maybe more around if you included pre-randomization fluid, maybe more around 1.5 liters. But still, I would argue, relatively low volumes of fluid administration. Because they had such large numbers, despite the low volume, they did show a treatment effect, a statistically significant difference in chloride levels and bicarbonate levels in those that were randomized to each arm. But when you look at the absolute difference in terms of chloride differences from 105 to 106, not, again, monumentally different. The primary outcome in SMART was a statistically significant reduction in the balanced crystalloid arm. Again, this is in the composite outcome, and you can see that a p-value of 0.04, this was borderline in terms of benefits. And when you looked at the individual components of the composite, none of the individual components were statistically significant, but when you put them together for the composite, it was. In terms of the SMART trial and how it guides practice, I think that there's some amazing things that the investigators with SMART were able to accomplish. This was an incredible number of patients enrolled in a pragmatic RCT addressing fluid therapy in the ICU, and the largest number of patients we've enrolled in a trial addressing fluid therapy to date. They were able to take advantage of administrative data sets, not a lot of bedside, I don't think really any bedside data collection. This was all from their EMR and from administrative data that was already being collected. And surprisingly, given the cluster design, little contamination between arms. I've suggested a couple of these along the way, but I think that before we say that this is going to change our practice dramatically, is that I think that there's some important caveats to keep in mind as well. This was a relatively low-risk population, at least low risk for ICUs in Canada. I again, don't know how things might compare to ICUs here or in the Asia-Pacific region. It was an unblinded trial, but perhaps the risk were smaller given the fact that it was a cluster design. Done in a single center, we saw a borderline effect in a composite outcome and relatively small volumes of fluid administration. SMART was the trial done in the critically ill population. At the same time, a parallel trial was done in non-critically ill patients. So if a patient presented to the emergency department and was not destined for the ICU, they got enrolled in the SALT ED trial. Despite not being critically ill, patients had to have received at least 500 mils of crystalloid to be included in the trial. And again, here it was randomized by months, so they crossed over month by month within the same emergency department to receiving either ringers or plasma light versus saline. The primary outcome here was hospital-free days. They did also report MAKE 30. This is what their randomization schema looked like. As I mentioned, single center, but they were randomized to which fluid they started with and then crossed over for a year and a half from there. Again, relatively low volumes of fluid exposure. Patients received about 1 liter of study fluid altogether. And they found no difference in their primary outcome of hospital-free days. However, similar to the SMART trial, there was a statistically significant improvement in their composite of MAKE 30 and those in the balanced crystalloid arm. Again, none of the individual components of the composite met statistical significance, but when you looked at the composite in totality, it did. How do we walk away from these trials and contextualize where we are today? I think that at least where we stand right now is that I don't think we can give absolute answers in terms of whether normal saline is best or balanced crystalloid is best. I would argue that given the data that we have, perhaps we're moving towards the idea that balanced crystalloids might be optimal, and I put us moving that way on this spectrum. But what I would suggest to you is that we are not yet at a point where we can turn to people using normal saline and telling them what they're doing is wrong. I think we need further data before we're able to conclusively say which fluid is best. And I think it's a good thing because I think that there's a number of randomized controlled trials that are continuing to enroll patients examining this exact question, including the PLUS trial, which is being done just across the sea there in Australia, New Zealand, the BASICS trial being done in Brazil, the FLUID trial, which is being done by one of my colleagues in Canada, Laura Lynn McIntyre, and the FISH trial, which is my own, examining this research question. So I think in the next few years, we're going to have a lot more data informing this clinical conundrum. I'll spend just the last couple of slides introducing you to my own trial, the FISH trial, and why I think that there are perhaps some benefits to the design that we chose. And we're specifically, my interest is in septic shock. I think that sepsis is unique in terms of fluid resuscitation and distributive nature of the shock itself. And so we're only looking at patients with septic shock and whether an approach of using saline versus using Ringer's lactate is beneficial. This is part of a program of research that included systematic review, the network meta-analysis that I showed you. We did a pilot randomized controlled trial last year and have now moved forward with 10 centers and enrolling 200 or 300 patients, all in Canada for right now, into this individual patient RCT. And what I will tell you from the pilot is, as opposed to SPLIT and SMART, where patients received about 1 liter of study fluid, in the FISH pilot, study patients received 7 liters of study fluid. So the idea here being is that we're taking a sicker subpopulation and giving them a large volume of fluid exposure to see if that makes a difference. It's a blinded RCT as well, the FISH RCT. This is blinded fluid, which is, again, either saline or Ringer's lactate hung at a patient's bedside, and the fluid cart, which is, we make it as convenient as possible for nurses. It's been wheeled to the patient's bedside. My last slide in terms of take-home messages, I believe crystalloids should be your go-to for initial fluid resuscitation. I can't tell you for certain whether albumin has a role or not, but at the same time, for those that choose to continue to administer crystalloids, I don't think that that's the wrong approach by any means either. It's possible that balanced crystalloids could be the optimal fluid, but again, I don't think we're yet at a point where we can tell people using saline they're doing the wrong thing. Thanks very much, and be happy to take a question or two if they have them.
So, Bram, we actually do have a few. Starting off, I think we'd like to ask, do you have any data on colloid use in neurocritical care?
Yeah, it's a good question. They did do subgroup analysis from the SAFE trial, which is probably the largest data that we have examining those with albumin. And there was, from what I can remember, a slight signal for harm in terms of mortality. I think people get very scared administering colloids to the neuro population. So it tends to be those isotonic crystalloids, more specifically normal saline, that people preferentially administer. I know a lot of our neurosurgeons at our own center even get skittish administering those slightly hypotonic fluids like Ringer's lactate. And it's been an exclusion in our trial and an exclusion in a number of the other crystalloid trials as well. So, so I think albumin people are certainly hesitant about administering, and starches we can't even get a hold of in our center anymore. So I don't think it's as relevant a comparator.
Great. Another question about related to colloids. So in patients in shock with third spacing, for example, those patients with liver cirrhosis or nephrotic syndrome, in your opinion, what would be the more appropriate fluid choice? Is it albumin or crystalloid?
Yeah, I mean, like I say, I admitted the fact that I think there's very significant geographical variation and center-by-center variation in terms of albumin administration, or so I've learned. Even within the same nations or the same regions, one hospital might be albumin file and another not. My own practice in the patient that you suggest, Andrew, is that I certainly would start with crystalloid, but I would have a low threshold for adjuvant administration of albumin once I was a couple of liters in. That's my own practice, and I acknowledge, like I say, that the evidence is not necessarily there to back it up, but we haven't really examined this recipe of using different fluids for resuscitation. So that would be my approach, but as I said, I think that if somebody chooses to just use crystalloids, I think even in that patient population, they wouldn't be wrong.
Okay. Another question about colloids again. So in your practice, how do you give the albumin? Do you run it as a infusion over 2 to 4 hours with 25% pure albumin, or do you mix it with the crystalloids in scenarios like passive leg raise?
Our albumin comes pre-mixed from Canadian Blood Services, and I think that variation in chloride concentration that I showed you probably essentially comes down to what it's mixed in, and that's probably the different ways that it gets prepared at the industry level is what contributes to that. So I tend to run as an infusion or bolus, most commonly probably a bolus, maybe a 5% or 500 mils over an hour. I do not think that 25% albumin is a resuscitative fluid. I think that some people give 25% albumin to help facilitate diuresis. There's a couple of smaller CTs looking at giving it administering it with furosemide, but my sense is that, and the data, I think, at least the studies that have not really examined 25% as a resuscitative fluid, but rather 5%. I
think we have time for one last question. How does the balanced crystalloids compare among themselves, for example, between lactate and plasma-like?
I think it depends on who you talk to. I think a lot of industry folks would like to try to tell you that plasma-like is superior in terms of its perfect balance of electrolytes and composition. There is really only physiologic data when it comes to comparing some of the balanced crystalloids. I have a postgraduate student right now that's about halfway through a systematic review and meta-analysis comparing amongst the balanced crystalloids, and there's a dearth of data when it comes to patient-important outcomes. So My sense is that they're fairly equivalent, and given that, go with the cheapest option, which I think tends to be more the Ringer's lactate or Ringer's acetate, or the balanced crystalloids that have been around for longer.
I think you're running a lot of questions. I'm going to ask this last question then. Would it be simpler to define a danger range for serum chloride levels rather than doing so many complicated studies for fluids?
I mean, I think we don't know what the impact of hyperchloremia is. Again, is there a protective element to it? Is there a dangerous range? I think we all see those patients that are hyperchloremic. I mean, I got this research question because when you resuscitate a patient with a lactic acidosis and the next morning you've been able to bring the lactate down, but they're still acidotic because now the chloride's 125, it felt like this patient's going to be difficult to wean off the ventilator because they're going to be Kussmaul breathing, and I still have acidosis to deal with. So I think we think that there's harm with hyperchloremia, but we don't know. So I think it's hard to define a danger zone when we're not sure what the impact of this physiologic outcome is on patient-important outcomes. So I really think that we do need the RCTs that are focusing on the patient-important outcomes to inform practice.
Okay, I think in view of time, we will move on. So thank you so much, Bram.
Thank you.
Let's give him a round of applause.